Sampath Kumari ma'am, Dr. Sujata Dalvi, and Dr. Saravana Kumar sir, and with all our TN Fog office bearers here. So I'll be talking about a very important topic today, that is gender urinary syndrome of menopause. Is my screen visible, sir?
Yes, it is visible.
Yes, ma'am.
Full screen. Yeah.
Is it seen? No.
Yes, yes.
I'm see. Oh, wait, sir. Just a minute. My screen. Yes. So full screen, no, sir?
Yeah.
Yes, Madhu.
Yes. Jairani ma'am, hi ma'am.
Yes.
Good evening, ma'am. Yes.
Yes. Welcome, ma'am.
So, as such, gender urinary syndrome of menopause, it is a highly prevalent condition which affects more than 50% of menopausal women, and this number increases to more than 85% just after 6 years of menopause. But it is very often underdiagnosed and also unreported, because very often women as such fail to take medical attention because of the fear of embarrassment and also because of numerous religious, cultural, and social beliefs. There is also a lack of awareness about the effective treatments that are available for GSM, and because of this, women tend to suffer in silence. As such, the term GSM was actually coined only in 2014 by the North American Menopause Society and also the International Society for the Study of Women's Sexual Health. Before that, it was called by various names like vulvovaginal atrophy. So, as such, because all these symptoms are due to the fall in estrogen after menopause, the term GSM was coined. It is a chronic and progressive condition, and it has a substantial impact on the quality of life. So it affects not just the psychological well-being of the women, it also affects the interpersonal relationships and also the professional life and also the sexual experiences. But very often, as the woman doesn't actually come out with the symptoms unless asked, very often we clinicians, we fail to ask the menopausal women the symptoms about GSM. And the diagnosis as such, it relies entirely on the medical history, the symptoms, and also on the physical examination. Coming to the etiology and pathogenesis, the prime culprit here is the hypoestrogenism after menopause. Along with this is the reduced levels of circulating androgens, which also leads to various sexual dysfunctions after menopause, and also there is age-driven degenerative process. All this together cause anatomical and functional modifications of the urogenital tissue. Both the genital and the lower urinary tract, as they have a common embryonic origin, they share a common estrogen receptor function. Because of this, both the genital and the urinary tract are affected after menopause. Estrogen plays a big role during the reproductive period because it is a vasoactive hormone. It increases the blood flow to the urogenital system, and also it helps with the vaginal lubrication. It encourages the epithelial proliferation of the tract and also formation of the vaginal rugae, and it also helps in the maintaining the environment of the urinary tract. So after menopause, what happens? Because of the fall in estrogen, there is a decrease in the vaginal cell glycogen. And because of this, there is a change in the vaginal microbiome, and this leads to an increase in the vaginal pH. So this increase in the vaginal pH makes the women more prone for vaginal infections after menopause. There is also the atrophy of the urethra, and there is an increase in the urethral epithelial transitional cells after menopause and reduction in the intermediate and superficial squamous cells. And also there is also a lower genital tract, the urogenital tract atrophies after menopause. Not able to, yeah. So this fall in estrogen, it also causes reduction in the collagen and elastin. This leads to a loss of vaginal rugae. And the vaginal epithelium, because there is increase in the only the intermediate cells, the vaginal epithelium becomes very pale, friable, and it becomes very easily it becomes because it's friable, it can very easily tear and bleed, especially after intercourse. Hypoestrogenism also causes loss of lubrication, and it causes loss of elastic functions in the vagina, causing irritation and sexual trauma. The vagina also becomes shortened and narrowed, and this leads to dyspareunia. And the bladder and the urethra also become atrophic, and there is also a reduction in the pelvic floor strength. Because of this, there is impaired urethral closure pressure, and there is urethral sphincter dysfunction. So all this contribute to prolapse, urinary frequency, urgency, and also urinary incontinence. So here, after menopause, there is a loss of, because of the reduced blood flow to the vagina, there is loss of the vaginal fornix, there is thinning of the vaginal wall, and there is loss of rugal folds in the vagina, decrease in the vaginal length, and also atrophy of the labia minora and majora, and narrowing of the vagina. So as such, the utmost importance is when the women comes to us, understand the history, and all the perimenopausal women should be asked about leading questions about genitourinary symptoms, because unless we ask, they might not open up. And definitely, if the right questions are asked in the right clinical setting, in a sensitive manner, the woman definitely, she will open up about her symptoms. Especially, one thing to be kept in mind is patients on chemotherapy, that is after cancer patients who are on chemotherapy, or who were on chemotherapy, who underwent surgery for any kind of cancers or radiotherapy, they have a higher incidence of GSM. And patients also with inflammatory bowel disease, diabetic patients, patients with multiple sclerosis and stress, they're also associated with aggravation of symptoms of GSM. And certain drugs, they aggravate symptoms such as tamoxifen, antihistaminics, decongestants, and antidepressants. So history of drug intake also is important. So how does the patient present to us? She might present with vulva symptoms like dryness, itching, burning, and when we examine, we might find labia majora shrinking, loss of pubic hair, labia minora thinning or fusion, vestibular pallor, and there might also be clitoral hood retraction. She might also present with vaginal dryness, itching, or vaginal discharge, or also bleeding. And we might find the vaginal mucosal pallor or erythema or petechiae. There might also be loss of moisture and loss of elasticity, loss of the vaginal rugae, and flattening of the fornices on a perspeculum examination. She might also present with urinary complaints like dysuria, increase in urinary frequency, nocturia, urgency, and recurrent urinary tract infection, and also stress incontinence or urge incontinence. We might find on examination meatal stenosis or polyp or prolapse, and also and also petechiae, erythema, fissures, and ischemia of the vaginal vesicle trigone. She might also present with sexual dysfunction like dyspareunia, decreased or delayed orgasms, reduced lubrication, decreased libido, and postcoital bleed. And we might find a shortening or narrowing of the vagina. So one thing to be kept in mind is physical appearance does not always correlate with the severity of symptoms in GSM. And in case we examine her and we find a normal external genitalium urinary tract examination, but that doesn't exclude the diagnosis of GSM. So next, when we go to investigations, as such, for diagnosis of GSM, investigations are not necessary. We go by the presentation history and symptoms as such. But then again, certain investigations, it is better when she comes to us that we do certain investigations to rule out some conditions. Cervical screening, if it has not already been done, and a perspeculum exam, and also a perspeculum examination. Initially, it might be uncomfortable or painful, but it can be done after starting a local estrogen or lidocaine ointment or gel. In this case, after that, a perspeculum examination might comfortably be done, maybe preferably with a smaller speculum. And urine routine and microscopy for urinary symptoms can be done. And suppose in case of abnormal vaginal bleeding, relevant investigations to rule out any other cause of abnormal vaginal bleeding, either vaginal or cervical or uterine causes, this has to be ruled out. And in case if she comes with vaginal discharge, a vaginal swab might be needed to exclude any infections. And suppose in case when she presents to us, we might take this as an opportunity to rule out any systemic diseases. So the primary principle of GSM management is to restore the urogenital physiology and also to alleviate the symptoms. So this is the primary principle of GSM management. So what are the management strategies for GSM? So primarily it is first the non-hormonal interventions. This is the first line. Next, we go in for the local hormonal therapy. And if that doesn't work, the next option is the systemic hormonal therapy. And lastly, the procedural interventions. So non-hormonal interventions, these are the first line and is generally considered safe, effective, and well tolerated. And basically, especially in women when they have the starting of the symptoms or mild symptoms, and also in patients who we need to avoid hormonal therapy or have contraindications like history of breast cancer. For these patients also, non-hormonal interventions serve as the primary indication. And these non-hormonal interventions are basically the vaginal moisturizers, the vaginal lubricants, pelvic floor exercises, and also behavioral modifications. So coming to vaginal moisturizers, these moisturizers need not be used just before sexual intercourse. This can be used every day, and it helps to alleviate the discomfort due to vaginal dryness, due to atrophic vaginitis and vulvar or vaginal atrophy. And it helps to maintain the vaginal hydration and improve tissue elasticity. And they often contain hyaluronic acid and polycarbophils, so they help to retain the moisture in the vaginal epithelium. Next, the vaginal lubricants. These are used during sexual activity to reduce sexual friction and dyspareunia. They are bioadhesive. They attach to the mucin and the epithelial cells of the vaginal wall and retain water. They mimic the vaginal secretions with a pH similar to the vaginal secretion of 4.5. And according to WHO, one thing to be looked for is the osmolality should not exceed 380 milliosmoles per kg in order to prevent epithelial or tissue damage. So we have various formulations of these vaginal lubricants. The one is the water-based lubricants. These are widely over-the-counter. They are available and they cause fewer side effects. But again, because they are water-based, they tend to dry up soon and they may require frequent reapplication. Next is silicone based. They are longer lasting and they are suitable for even more severe symptoms as they're longer lasting. Next, the oil based lubricants. They provide good lubrication, but they might not be compatible with latex condom. And also one concern with these oil based is they can change the pH in the vagina and make and cause increased risk of infections. Next, coming to the pelvic floor exercises, the Kegels exercise, the women should be taught and stressed that Kegels exercise definitely has to be done in order to help her with the urinary symptoms especially. And also it helps to enhance the pelvic organ support and also improve the vaginal health. Next, the behavioral modification and the regular sexual activity or vaginal penetration either through intercourse or with vaginal dilators. It really helps to maintain the vaginal elasticity and also helps to maintain the blood flow of the vagina and also promote vascularization of the vagina and reduce atrophy. Next, if the patient is not okay with the non-hormonal therapy and if the symptoms worsen, we can switch over to the hormonal therapy. Hormonal therapy as such plays a very important role in patients with GSM who don't have any contraindications for its use, especially estrogen therapy, because it directly addresses the underlying cause, that is the hormonal deficiency, estrogen deficiency after menopause. So local estrogen therapy, this is the cornerstone of GSM management. So local estrogen application is the one that effectively restores vaginal pH. It improves the epithelial thickness and it helps to elevate the symptoms with minimal systemic absorption. So vaginal creams, vaginal tablets and rings, these are the ones that are available for local estrogen therapy. So here, out of these, estradiol is the one that is most studied and it is a gold standard for local application. The estradiol is less potent with lesser side effects. We commonly use it like Premarin creams, but as such, it is very popular off-label, but it's not approved by FDA. So these are the two most common preparations, that is the estradiol and estradiol. The estradiol also comes as suppositories, 7 mg vaginal suppositories. The estradiol vaginal cream of 0.01, this is another one that is commonly available these days, and the Premarin conjugated estrogen cream, and also the estrogen Avalon cream. So one thing to be kept in mind is if the treatment is started earlier, the earlier we start when the woman presents with symptoms, it helps restore the anatomy and physiology. It prevents progression to more severe changes like labral resorption or clitoral atrophy. So the earlier the treatment, the better it helps to restore the women's natural anatomical and physiological changes. So suppose in case if the symptoms do not improve with local vaginal estrogen, what do we do next? Either try increasing the dose of vaginal estrogen or try changing the preparation. If she's taking estradiol, try changing to estradiol. Or you can also consider DHA, which is now available as Pregasert vaginal inserts. And also you can also combine two local treatments. But if none of this works, we'll have to switch over to systemic MHT, menopausal hormone therapy, provided there are no contraindications. So DHEA as such, it is a steroid hormone, and which we know it is crucial for conversion of cholesterol to androgens and estrogen. That is why this DHA preparation also helps in it helps in maintaining the urogenital physiology after menopause. And it can be given both orally or vaginally. It improves the vaginal cellular structure, lowers the vaginal pH, and also helps in vaginal atrophy, sexual and also sexual dysfunction. And orally, till now, studies have shown that a daily dose of 50 mg over a year, it is found safe and effective. And and after this, there were improvements in the female sexual function index with patients reporting better sexual desire, arousal, lubrication, orgasm, and satisfaction, and reduced pain after using it for around a year. Next, testosterone vaginal gels can also be used for one condition after menopause, that is only for women with hypoactive sexual desire disorders. So this is one condition where we can also give testosterone. But again, other than this condition, for other conditions, there is no data to support use of testosterone for GSM. So the topical hormone treatments which are effective for GSM are: one is the vaginal cream, that is 17 beta estradiol. Next, the conjugated equine estradiol also. Next, vaginal tablet estradiol hemihydrate can be used. Vaginal ring with 17 beta estradiol can be used. And this is the Prestron. The Prestron is the DHEA vaginal insert, which can be used once a day. And the vaginal cream testosterone, especially for loss of libido. And the vaginal gel, that is estradiol vaginal gel. So for any treatments, you can initially start it once a day and then slowly reduce it to the minimal effective dose. Try to reduce the dose to 1 or 2 doses per week and keep that in maintenance. Next, suppose if she doesn't, symptoms don't resolve with local therapy, we have to move on to the systemic hormone therapy. And especially with women with other symptoms of menopause, like vasomotor symptoms, which is also having other symptoms along with GSM, we can go for systemic therapy with, provided there are no contraindications. We can give oral or transdermal estrogen for these patients, and typically they take 6 to 8 weeks for the symptoms to resolve. And one thing to be kept in systemic hormonal therapy is when we're giving local hormonal therapy, we need not give progesterone for endometrial protection of the endometrium. But in case of systemic hormone therapy with women with an intact uterus, we'll have to definitely give progesterone to prevent endometrial hyperplasia. So a biosimilar hormone like either micronized progesterone or dydrogesterone is preferred. And also for endometrial protection, instead of oral progesterones, we can also use the levonorgestrel intrauterine device. So this is the dose of MHT. The standard dose is 2 mg. We can start it with that. And then if she tolerates, go on to the lower dose, that is 1 mg. And also tibolone also can be used safely for patients with GSM symptoms. Next, the various regimens. I'll not be going into details about this. Next, one thing to be kept in mind is look for the contraindications before starting the oral menopausal hormone therapy. That is previous history or current breast cancer, any undiagnosed vaginal bleeding, thromboembolism, or history of any coronary artery disease, and also in women with active liver disease. So primary indications for MHT, one is primary, that is women with GSM who don't respond to local therapy, women with vasomotor symptoms, and also for the prevention and treatment of osteoporosis. So these are the primary indications where we can use MHT. It also has numerous additional benefits like improvement in sleep, muscle and joint pains, mood disorders, improvement in sexual dysfunction, decrease in colon cancer risk, decrease in diabetes or metabolic syndrome incidence, benefit in cardiovascular disease, and also helps in cognition improvement. One thing to be noted while giving is body identical hormones like micronized progesterone or dydrogesterone is more safe and more benefits if it is started within 10 years of menopause. And vaginal estrogen, when we're giving long term, there is no need of using progesterone for endometrial protection, as I already mentioned. And vaginal hormones, they also improve urinary symptoms and also help in recurrent UTI symptoms. But patients should also be counseled that 10 to 25% of women who are on systemic MHT, in spite of taking systemic MHT, they might have persistent urogenital symptoms. So for these women, along with systemic MHT, we can also add vaginal hormone therapy again as an add-on. So before going in for hormone therapy, take up a detailed history and rule out any contraindications. And endometrial sampling, as such, it is not required. But if the woman has any history of postmenopausal bleeding, she might need a thorough evaluation for that. And selective estrogen receptor modulators. Out of this, ospemifene is the one that is widely studied, and it is the only SCRM which is approved for treating dyspareunia and vaginal dryness that is associated with GSM. It is beneficial for both urinary and sexual symptoms, and it has estrogenic effects on vaginal tissue, but it does not affect the endometrium. So it is very safe for women to whom we cannot give estrogen. The dosage is 60 mg daily, and this has an equal effect compared when similar to giving local estrogen therapy. So one side effect with this is hot flushes. So in women who already have vasomotor symptoms, this might not be preferable. Next, coming to the last thing, that is procedural interventions for women who still have persistent symptoms. Laser and radiofrequency therapy can be tried. So nowadays we have vaginal laser treatments like fractional CO2 lasers, erbium YAG laser, and also the diode lasers. They can be used around 6 to 8 cycles can be tried. And also radiofrequency devices also have similar effects because as they give control thermal energy to the epithelium, so it helps in increasing the growth of the vaginal epithelium. They help in they stimulate the proliferation of the epithelium and vascularization and collagen formation, and help to improve the hydration, elasticity, and muscle tone. And also PRP therapy has also been tried, though we don't have large RCTs, and we don't have many systemic, we don't have big studies regarding this. But then again, um, it is said that the growth factors and the cytokines in PRP, they promote healing and regeneration and improve tissue quality. So it has PRP along with laser. It is said to improve the symptoms more quickly. And generally, surgical interventions are not recommended for GSM, but some women who have, along with that, they have any prolapse or who might need urethral things. In these cases, it might be needed. So along with all these therapies, adjunctive therapies are probiotics. These women, because the urogenital flora is altered, they might require probiotics and vitamin supplements, especially vitamin D and E. Might be of benefit. And one important thing to be considered is the diet and the lifestyle modification. A balanced diet rich in phytoestrogens, which are more available in soybeans and also lentils, nuts, all these. We have to advise a patient with regular physical activity, including aerobic and strength training exercises, avoidance of smoking and alcohol. And basically, all these contribute to overall well-being and tissue resilience. And there's also been a positive link between maintenance of vaginal elasticity and lubrication associated with regular sexual activity. So this also has to be stressed, and patient has to be counseled that this because we cannot expect with any treatment or therapy, we cannot expect immediate response. So any treatment might need at least 6 to 8 weeks for the benefits to be seen. And hence an open communication is needed, and this can, in a supportive environment, is always necessary. And especially in women with gynecological cancers and GSM, in these women, what is said to be as oncological treatment induced GSM. So these women, sometimes we encounter younger women who undergo premature, especially women who undergo premature menopause due to some treatment for gynecological cancers. So these women, pelvic irradiation or surgery might have affected the blood flow and nerve supply, and this can lead to dryness, stenosis, and scarring. And these can cause severe urogenital symptoms, psychological distress, and sexual dysfunction. So here, vaginal moisturizers and lubricants might help. Some women might need local hormone therapy, and these women, especially after taking local hormone therapy, they need to be reviewed every 3 months. So as such, she has to be advised to avoid irritants like perfumes, powders, some fragrance soaps, bath additives, deodorants, and panty liners or spermicides, because many of these brands, they have these fragrances which might be irritant. And tight-fitting clothes and long-term use of sanitary pads or synthetic materials can worsen symptoms. Cotton underwear is always preferable to synthetic fibers. And to conclude, effective management of GSM, it requires a tailored, individualized approach, and this includes the hormonal treatment, non-hormonal, hormonal, and procedural options might also be needed. The first line treatment always includes lubricants and moisturizers, as it is safe in most patients. But when symptoms persist or are moderate to severe, hormonal therapy is needed. And topical hormone therapy, fewer side effects than systemic hormones, and this forms the cornerstone of GSM treatment. And always remember, if we have to go in for systemic hormone therapy, menopausal hormone therapy offers more benefits in women who are less than 60 years of age and less than 10 years of menopause. In these women, definitely the benefits outweigh the risks. And effective communication, counseling, and encouragement to the patients to make informed decisions. This is very important to enhance the quality of life of the women affected by GSM. So thank you once again for the patient listening.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Madhumita, for the elaborate talk on
Thank
GSM.
you,
And we now have our expert inputs from our chairpersons, please. Dr. Raza Lakshmi, Dr. Radha Madhavi, Dr. Yoga Lakshmi. Do you have anyone?
Wonderful talk, Madhumita.
Thank you, ma'am. Thank you so much.
I think you have
If
covered
you don't
everything.
have any,
Yes, very comprehensive talk, Madhumita. Congratulations.
Thank you very much, ma'am. Thank you. Thank you, Madan sir and Prerna ma'am, once again. Thank you so much.
Thank you. So we now move on to our next session, that is on premarital counseling. And for this, we have none other than our very beloved and very revered Dr. S. Sampath Kumari Madam, Vice President, past Vice President Foxy, for this deliberation. And to chair this session, I invite Dr. Swati Rathore, past Secretary of Vellore Society, Dr. Archana Ambujan, President, Productivity Society, and Dr. Meena Mahalingam, Secretary, OGSSI. So can we have Dr. Dr. Rita Vijay Selvi, also President, Vellore Society. Do we have any of our chairpersons joined with us? Ma'am, you can start off your deliberation.
I'm there.
Sampath, ma'am.
Yes,
I'm Dr.
Yes,
Meena Mahalingam, joined from Chennai.
Okay, ma'am.
Yes, welcome, ma'am.
Ma'am.
Thank you for the opportunity, Dr. Madan sir and Prerna Keshan sir and Sampath Kumari madam. Very nice session. Thank you.
Thank you, ma'am. Thank you. Sampath, ma'am, you can share your slides.
Sharing. Yes, sir. Can you see my screen?
Yes, ma'am.
Yes, ma'am.
You can see.
Yes, sir. Thank you, Dr. Madan and Dr. Prerna, for this wonderful session. And you had a wonderful and very elaborate talk by Dr. Madhumita. Now, this is very simple and practical points for the premarital counseling. See, here the premarital counseling is structured, often short-term therapy process designed to help engaged couples build a strong foundation for the marriage. So whenever there is always it is better to have the premarital counseling such that we can reduce the incidence of misunderstanding in later. So this premarital counseling or therapy helps partners have a healthier marriage by setting realistic expectations, improving their communications, and working on conflict resolutions. So this conversation prepare partners when problems emerge down the road. So this is the definitions and what is the importance of the premarital counseling. So why it is important? That is mainly for the communication skills. So with this counseling, they can have the effective communications and they share their knowledge and they can share their thoughts also. It is a cornerstone for successful relationship. And the couples have better ways to express their thoughts, feelings openly and honestly. But it should be very honest, this communication skills. And the conflict resolution. So when they have this there may not be the face of disagreements in future. So this counseling teaches techniques for resolving the conflicts. If at all, if happens also, how to resolve the conflicts in a healthy, constructive manner. And the finance. So the financial problem, the girl or the boy, they may have some dreams and they may not be knowing about the finance situations. So with this counseling, they can have the common source of stress, which is mainly with the finance. So the financial expectations and plan for managing their finances can be helpful. If both of them are going for the job, whether they have to continue or one have to look after the family. So this planning will be very, very helpful. Then the family and the parenting. Sometimes nowadays the people they plan that they don't want to have the children now. They want to earn and they want to spend time freely for some time and then to have the children. So this planning about the children, whether to have the one baby or two baby, whatever it is, that family and parenting can be very, very helpful. That can be done during this counseling. And the personal values and beliefs. So each one may have some ambitions and they may have some belief and some may expect that they want to go to abroad and some will have the intention of staying here. So in this, the counseling will explore about the personal values and the beliefs. And finally, about the intimacy and sexuality. So this is also very well, and for this counseling, always it is better to talk about the intimacy and the sexual health and addressing the expectation. What is the expectation from both sides? That is will be very, very understood. So these are all the importance why the premarital counseling has to be given. So the objectives is because of this, the finance, parenting and roles, it reduces the, as per literatures, the divorce rate by 31%. So the medical conditions affecting that can affect in the pregnancy can also be reduced and prevent the hereditary and infectious diseases and have the promote a healthy lifestyle, improve the fertility outcomes and ensure the psychological preparedness. So this is very, very important. That is the psychological preparedness. So what are all the components for this premarital evaluation? Take about the medical history, whether they are the diabetic or hypertension, that is also important, the evaluation. Menstrual and reproductive history, family history of the genetic disease, physical examination. This can be, they can talk with each other, whether anyone is having the congenital baby. Like that, if at all needed for evaluation, this is very, very important. And about thinking about the menstrual and reproductive age at menarche, cycle regularity, symptoms of PCOS. These are all will be very, very helpful when they during itself, not only for the preconception counseling, but also for the premarital counseling. So the lifestyle, what is the diet habit? That will be very, very helpful. If they are obese, what is they are taking the fiber diet and what is the methods of diet and the physical activity. Because this physical activity, so obese means they themselves have the discussions about the physical activity and the substance abuse such as alcohol and smoking, occupational exposures, what is the type of job they are doing, what will be the exposure, whether it will produce any complications in future. These are all can be discussed. So why this premarital counseling and this preconceptional counseling is important in obstetrics and gynecology? This is mainly to reduce the maternal and neonatal complications, that they are aware of the high risk of pregnancies and the pre-pregnancy optimization and planned conception and improves maternal health indicators. The obesity, if they are obese, they can make the BMI to be around less than 30, such that the incidence of PCOS, GDM, the hypertensive disorders can be reduced. And if the obese under the engagement and during the premarital counseling, they talk about each and the lifestyle changes and the exercises, the obesity can be reduced, because this has to be counseled. If because of this obesity, what can happen? The maternal complications, the birth complications, the increased LSES and the offspring complications. These complications has to be informed such that the weight has to be reduced. Then the thyroid. Now the hypothyroidism and hyperthyroidism, not only for the conception, it is also for the bleeding. It can be a heavy bleeding, or if the bleeding may not be there, and it will interfere with the ovulations. The thyroid, you have to talk about the thyroid, and it has to be screened. What is the TSH level, and it has to be maintained by 2.5 ml international unit per liter. And the diabetes. Suppose they are the known case of diabetes, that is the pre-GDM, we cannot take known case of diabetes, means we have to talk to them, and the level of the HbA1c should be maintained before that marriage. They should get, if they are planning to have the baby earlier, means the HbA1c control, the sugar should be controlled. It should be maintained with the level of the less than 6.5, and we have to counsel about the diabetic complications. If it is HbA1c is more and the sugar is more, what complications are about the congenital anomalies, abortions, and all this has to be explained. This also a part of the evaluations with the premarital. Then the hypertension. Always we have to take the BP, and if they are known hypertension, means whatever needed. That is after a pregnancy, we cannot go with the AC inhibitors. So the BP has to be controlled before, and if needed, the ophthalmologic and the renal function test has to be evaluated. Thus history, as I told, the alcohol exposure and smoking, and the importance why it is needed. Because of the alcohol, that can be the growth restriction, neurodevelopmental anomalies, and the smoking can produce the preterm infertility and the placental complications. Baby can also go for the preterm birth. So this history has to be elicited and counseled to stop this type of exposures. And the genetic counseling. Suppose if there is any family history of congenital anomalous babies, nowadays everyone knew about what is thalassemia, what is sickle cell disease, whether it is the major or minor. If anyone is suffering from that, that can be evaluated. If it is present, means you can also have the blood test before the marriage itself about the hereditary disorders and the risk estimations of the offspring. Then comes the health educations, reproductive health educations about the fertility awareness. Now the people before the marriage itself, they see with the AMH whether they can become weight or what to do. That has to be evaluated. About the ovulation awareness, if they are thyroid and obese, and the fertility window educations, when the ovulation can happen, when what is the safe period, which is the unsafe period, and the ideal age about the reproductive age. If they are more than 40, means the elderly, they can go for some anomalies. So these are all the factors which has to be explained. Of all this, the sexual educations, most of the girls, girls or boys, they do not know about the sex also, the coitus, they do not know. So in that cases also, we have to tell how the coitus has to be performed, how the pregnancy can happen. These are all the sex educations which has to be given. So the contraceptions, if at all they want to postpone, means we have to give the basket of contraceptions available, and whichever is suitable for them, whether it's tablets or this has to be told. And if they don't want to have the baby soon, means the contraception has to be counseled rather than going for the abortions. The choice with the advantage and the disadvantage, and the patient's choice, the method has to be given. Now, during the premarital counseling, nowadays we talk about the HPV vaccine that has to be given the 3 doses. That is after the 25 years. Hello, the adolescent, and sometimes the rubella vaccine also, on the duration about 5 to 6 months. During which time they should not become the, so that vaccination has to be given, and the infection screening, if at all needed, about the transmitted disease, the HIV and HBs antigen, if needed, that can also be done. These are all the methods of the premarital counseling and the premarital evaluation. So that to conclude, the premarital counseling acts as a foundational proactive investment that significantly increases marital success by fostering the improved communications, conflict resolution, and aligned expectations. So it helps couples address potential issues early and build stronger emotion, that is the emotional bonds, and establish the healthy long-term relationship habits rather than focusing on the wedding. So this is the way we have to, nowadays in most of the time we have the premarital counseling in many hospitals, and even in the government hospital setups we have the counseling in some hospitals. So I thank Dr. Madan and Dr. Prerna for giving me an opportunity, and I request all of you to vote for me. I am contesting for the FOXI president. The election year is 2026, that is from August 1 to 20. Please spread the message to your friends. Thank you. And the wonderful CME, Dr. Madan and Prerna, thank you so much. And I can see many of my friends from TNFOG. Yes, Archana.
Thank you, madam. That was such a crisp and enlightening talk on premarital counseling. I think need of the hour. Very nice it was, ma'am. Thank you.
Thank you, Archana.
Thank you. Thank you, Sampath ma'am. It was an excellent session. Covered entire detail about the couples getting emotionally, medically, socially, avoiding medical and genetic risk, infectious disease screening, and also awareness about fertility, avoiding unwanted pregnancies, supplementing with folic acid, and also the lifestyle factors, reducing obesity. Covered everything in detail without leaving any point. It was an excellent, comprehensive talk, madam. Thank you so much.
Thank you, Meena. Thank you.
Thank you.
Next, we will be waiting eagerly for Madhubala's talk. Yes, thank you. Thank you, Mother.
Request everyone to vote for Sampath Kumari madam from Oxy. Thank you.
She's our Oxy secretary. I have told her, wherever you go, you have to inform. All my Tamil Nadu people has to inform. Thank you.
Thank you, madam.
Yes. Wonderful talk, ma'am. Congratulations.
Madan, I have another one webinar. So
Yes, ma'am. Yes, thank you so much.
Thank you. Thanks, all of my dear friends. Thank you.
Yes.
Thank you.
Yeah, best wishes for you. Thank you.
Thank you, Madan.
Yes. Welcome, Madhubala ma'am.
Good evening, sir.
Yes.
So the topic given to me is sexual dysfunctions and infertility. Thank you, Dr. Madan, for including me in this webinar. This is a most important topic where we're discussing infertility, but very uncommonly discussed in our OPDs. So it is an introduction. Infertility affects 10 to 15% of the couples worldwide, and sexual health is an essential component of reproductive health. Sexual dysfunction is often overlooked in infertility clinics. Of all the infertile couples, this sexual dysfunction constitutes 40 to 60%, and the rates are higher compared to the fertile partners. Of course, both male and female partners are affected. So why to discuss about this sexual dysfunction? This influences natural conception, increases the sexual anxiety, and couples hesitate to discuss about their sexual issues even to their infertile specialist. Sexual dysfunction is viewed as infertility, and these both are bidirectional. So infertility in Asia is viewed as women's problem, and sexual dysfunction in Asia is viewed as a problem with masculinity. And male sexual dysfunction couples prefer to label as general infertility in order to avoid stigma to their own. So for infertility, sex becomes a necessity. So if there is sexual dysfunction, infertility is the norm. This sexual dysfunction can occur because of stress and performance pressure. It can affect both partners, like male sexual dysfunction and female sexual dysfunction. There are different types of sexual dysfunction, both in male and females. In females, it is common or hypoactive sexual desire disorder, arousal disorder, orgasmic disorder, dyspareunia, and vaginismus. For the males, it can be erectile dysfunction, premature ejaculation, delayed ejaculation, and reduced libido. There can be psychological factors which always play a role along with the physiological factors. Performance anxiety, which nowadays we can see in most of the young couples, fear of infertility diagnosis, relationship stress, and depression and low self-esteem. This is classified in ICD as 101, and a particular dysfunction, when diagnosed and present for at least 6 months, and in 75% of sexual encounters, causing significant interpersonal distress, is classified as sexual dysfunction, either in the male or in the female. For example, when a couple is suffering from infertility, there are so many other factors which is also involved in the sexual dysfunction. One such case is like this. They are married for 3 years, received letrozole for several cycles, then attempted HSG, then only we realize it is non-consummation. So the elephant in the room is infertility is defined as regular unprotected sexual intercourse, which actually has not happened between this couple. So we talk about semen parameters, tubal patencies, and ovulation, but the basic act of intercourse, which is much needed for the conception, is often forgotten and not often taken as a proper history. So the unexplained stories of non-consummation has been too much and too many. And 6% of the couples presenting to the fertility clinic have non-consummation. 34% did not easily disclose the sexual dysfunction. They always have a blame game. And 31% of couples subsequently had successful coitus after proper counseling and some form of treatments whenever they need. This is also popular among couples when they don't want to come to the infertility specialist or any other gynecologist for the sexual dysfunction, and they try themselves the intravaginal insemination. Even from remote places from our place, I had 2 to 3 patients. Initially, I didn't believe. Somehow the words pass among themselves, and they take the sperm in a syringe and they inject into the vagina. That's what they say, and I had to believe it because they are from a very remote village, and intravaginal insemination, sometimes they do give pregnancies. And the next problem is the timed intercourse. Are we at trouble or we are making the patients to trouble for timed intercourse? Let's see. Frequency of intercourse, the normal norms is 2 to 3 times a week according to NICE 2013. But timed intercourse increases the risk of stress and sexual dysfunction, and it does not improve the chance of pregnancy. Even JCU and British Association of Urological Surgeons have taken a prospective cohort study where they found the negative impact of timed intercourse in infertile couples. So what is the reason for practicing timed intercourse? Actually, it is 56% advised by the doctors during our ovulation studies and protocol. 36% they receive the knowledge from books, internet, relatives, and friends, and 7% by other means. So when comparing the probability of getting pregnant with regular intercourse and timed intercourse, of course, regular intercourse scores high compared to the TI. What does the Cochrane says? Cochrane reviews say the evidence was of low to very low quality, and there is insufficient evidence to conclude the effect of timed intercourse on clinical pregnancy. So how do the normal sex response occur? It is almost similar to male and female. It starts from the desire, and for males it is erection, and for female lubrication, and then penetration and orgasm. It has to happen accordingly and systematically. These things differ because the males and females have different thinking process about sex, and for the females it is always the need for commitment, and for males it is only the sex idea which always stays in their mind. So the differences in sexuality also matters very much in sexual dysfunction. For the females, only about 1/4 of women think about sex daily, and they always attach lots of emotion to sexual encounter, and they want lots of sex with the partners they love in a suitable ambience. But it is totally different for the male partner. The majority of adult men think about sex at least once a day. They attach very little emotion to the action, and they want lots of sex only. The ambience doesn't matter. So how to approach the sexual dysfunction and infertility? When coming to the males, ED is an opportunity to diagnose so many problems in male. When a male comes with erectile dysfunction, we can assess them in so many ways when we can always find out a cardiac disease in these patients because it is associated with the endothelial dysfunction, and lower urinary tract symptoms can be identified. Anxiety and depression because of high noradrenaline, and we can identify hypogonadism because of the low testosterone. So when you confirm ED in a sexual inquiry for all men, you also have to take out the exercise ability And if it is low risk, intermediate risk, or high risk, for the low risk, stress test has to be done. If they are against low risk, then we have to advise and treat ED. If they are high risk, if they fail the stress test, they have to be sent to a cardiologist for a full analysis. Princeton 3 consensus. This is a consensus where they optimize the sexual dysfunction and improve the cardiovascular outcome in erectile dysfunction men. So for this, the consensus says age, hypertension, type 1 and type 2 diabetes mellitus, smoking, dyslipidemia, sedentary lifestyle, and family history of premature cardiovascular disease all contributes to erectile dysfunction. So are these erectile dysfunction mostly psychological? It is not so, because physical erection is gradual onset. It is progressive in all situations, and with all partners, they have the erectile dysfunction. Inadequate response to the drugs we commonly give. Better erection in standing position than in lying down. But psychological onset, it will be sudden, off and on, and it will occurs in some particular situations, but has a very good response to the phosphodiesterase inhibitors. Precipitating and psychological factors will always be there, and morning erection suggests, but it cannot always confirm the psychological etiology. So what are the minimum investigations where we can do in erectile dysfunction? Physical examination is a must. We have to rule out diabetes, HbA1c, lipid profile if not assessed in the last 12 months. Total testosterone count should be done between 8 to 11 a.m. in the fasting condition. An abnormal test must be repeated after 2 to 3 weeks. One single test will not confirm the diagnosis. Penile Doppler is yet another test, whether it is normal, whether it has got arterial insufficiency or a veno-occlusive cavernous dysfunction can also be tested. Coming to these phosphodiesterase 5 inhibitors, they improve the erection because of arterial smooth relaxation and increased arterial inflow. So these are the commonest drugs which we use for the erectile dysfunction. But before starting these drugs, we have to exclude the possible reversible causes like hypogonadism, diabetes mellitus, and psychiatric illness. Cardiac evaluation is a must. And non-pharmacological therapy in the form of pelvic floor exercises and lifestyle changes should be always given the prior importance. And we have to explain about the drug, and it has to act only after adequate sexual stimulation. Without a foreplay, this drug cannot act. But we have to wait for some time, at least 15 to 30 minutes after the medicine is taken. Fatty meal will impair the absorption of sildenafil and vardenafil, but not tadalafil and amanafil. Absolute contraindications would be concomitant use of nitrate. For men with prostate conditions, if taking alpha blockers, then these drugs should be taken. If these drugs fail, then the lack of efficacy when the response rate is less than 63 to 75%. Non-responder, you can label them as a non-responder if the patient fails to respond to the drug taken on at least 6 to 8 occasions with maximum dose or after adequate sexual stimulation. Incorrect uses when the patient uses it before adequate sexual stimulation, and failure to wait at least 30 minutes after taking the medicine, and if the sildenafil is taken with the fatty food, and if undiagnosed reversible causes is not corrected. Then impotence will be the next step. Frequent dosing regimen you can give. Again, this phosphodiesterase inhibitors will be the drug of choice. Tadalafil 5 milligrams per day. Combining different forms of these drugs like tadalafil and sildenafil, because sildenafil is short acting without increasing the side effects, and long acting will be tadalafil. Changing to different drug can sometimes help, and if it is not helping, then we have to go for duplex Doppler ultrasound, arteriography, and dynamic infusion cavernosometry. So next line of treatment for these people would be intracavernosal injections, urethral suppository, penile implants, prosthesis, and penile revascularization surgery. The penile Doppler is not in favor of them. When there is premature ejaculation that always or nearly always occurs prior to or within 1 minute of vaginal penetration, or a clinically significant and bothersome reduction in latency time, at least about 3 minutes or less, or the inability to delay ejaculation on all or nearly all vaginal penetration irrespective of the partners, negative personal consequences such as distress, bother, frustration, or avoidance of sexual intimacy. And this occurs in 75% to 100% of sexual encounters. Premature ejaculation is nowadays commonly encountered in all infertility people. Whether this can affect fertility, ejaculation prior to vaginal penetration considered as the most severe form of premature ejaculation, typically present when they are having difficulty conceiving children, and 5% of this men suffer from antepartum premature ejaculation. What is the pathophysiology? Ejaculation is retarded by these 5-HT receptors, and ejaculation is facilitated by these receptors. So when there is a hyposensitivity of these receptors or hypersensitivity of the 1A receptors, then this premature ejaculation is happening. So what are the principles of treatment? Discuss the patient's expectations thoroughly. Treat them first if present, erectile dysfunction, chronic prostatitis or hyperthyroidism. And for lifelong premature ejaculation, pharmacotherapy is the basis and behavioral therapy will be the adjunct. When it is acquired in the middle, then behavioral treatment would be the first form of treatment. Then we have to add on to pharmacotherapy. Pharmacotherapy will be in the form of depoxetin, long-acting antidepressants, and tramadol on demand. Behavioral therapy would be squeezing technique, masturbation before coitus, and pelvic floor exercise, which is more important for both male and females. If there is no discharge or no sperms coming out, then they are not used to masturbation, then investigations like TRUS are normal. Then we have to plan for TISA or ICSI. But sometimes vibrators can help. Delayed absent ejaculation in men presenting to the fertility clinic. There was a retrospective cohort study of which 4.3% was diagnosed with ED and 57% had primary delayed absent ejaculation and 56% had secondary ejaculation and 59% had underlying erectile dysfunction. So ejaculation is emission plus expulsion. Sometimes these vibrators will always help them to. This is becoming common. Some men ask for these vibrators for their ejaculation. And coming to the female sexual dysfunction, vaginismus takes the first important role. We have to look at the vagina, vulva, and identify the different parts. We have to mindfully scan the body. Pelvic floor exercises should be taught to. And regular insertion of fingers or dilators, which is very commonly available in the Amazon or Flipkart into the vagina. We have to sensate focus exercises. This is the cornerstone of all the sexual therapy because it is a stepwise sexual therapy, which is the commonly being attributed to the female sexual dysfunction. That should be always a supportive partner. And pharmacotherapy in the form of antidepressants if needed. And Botox is also rising up for vaginismus. Dyspareunia can be superficial and dry, deep. Vaginal dryness, avoid lubricants. And if it is deep, we have to rule out endometriosis, PID, and if needed, hormonal therapy and surgical intervention. Management of low libido, lifestyle changes, improving the body image. Sex therapy was already discussed about the sunset focus, psychotherapy, and you can always advise them to go for a date night because everything should not culminate in sex. There should be lots of behavioral changes, lifestyle changes, some date nights, and sex should be the last resort they have to go for. Then their intimacy will improve and their sexual dysfunction can come down a lot. Testosterone and DHEA can also help in this low libido patients. These are the pharmacotherapy in FSD. Sometimes placebos, they do help. We can give them vitamin tablets and tell them this will improve your sexual dysfunction. And psychologically, you can change these patients. Sometimes it might work. So the best aphrodisiac, Masters and Johnson, who invented the sensate focus, because they say a structured sexual therapy is a sensate focus, and this has been structured by Masters and Johnson. They say an interesting and interested partner will be the best aphrodisiac rather than other drugs, what they use. And relationship with a new partner. Research on sexual function consistently demonstrates increased libido and pleasure in new relationships. When there is a marriage without love, there will be love without marriage. This is what the famous words by Benjamin Franklin. So what is the use of having sex when there are lots of problems? What is infertility? So we have to sit and talk with these couples about sexual dysfunction. Most of them might be having this when they come for infertility checkups. So no fertility test is perfect. Tubal patency, laparoscopy is not gold standard. AMH does not correlate with fertility. And semen analysis cannot accurately predict the male fertility potential. Sexual dysfunction, if it is the foundation or the bottom stone, then all these things cannot help a infertile couple. Nowadays, this is very common, interested in man and woman. A couple happily married for 4 years, infertility for 2 years, all investigations normal. I don't think this is a surprise because all of you would have been facing this problem now. Next week, husband came along and revealed that he is not interested and he is interested in his friend. So, sexual orientation, Alfred Kinsley, the father of sexual revolution, the human sexuality fluid that can change over time. So, the concept of sexuality is not necessarily fixed. It is not fixed only to a man or only to a woman. It can change over time. And this blame game, as already discussed, the problem is yours. Trying for pregnancy for 2 months, wife feels the pain. Wife says husband having ED, erectile dysfunction. So the blame game should be solved. So how to open this Pandora's box? What bothers you? This is what we have to sit and talk with these patients. We have to allow them to speak and provide guidance. That should be as a balance. Whether they have less stamina, less energy, no strength, no enjoyment, no interest in the partners, that has to be elicited in a proper way. And how to explore the sexual problems. There are 2 different models. One is the lofty approach. Second is the implicit model. Lofty approach is nothing but listening, observing, feeling, thinking, and interpreting their words. And implicit model is permission giving, assuring the client that his thoughts or beliefs are not negatively affecting the partner. Limited information, that is information about the particular sexual problem, is given to the client. Specific suggestion like censored focus and homework assignment should be given. An intensive sex therapy, insight-oriented and psychosexual approach to make him aware of his feeling. Both male and female should be separately counseled and talked to so that we can listen to them carefully and then we can interpret their words. So the take-home messages would be the fertility physicians should walk an extra mile to explore the sexual issues. They have to be non-judgmental. Couples' needs should always be taken in a priority. They have to be seen separately and alone. And in between legs and in between ears, that has to be prioritized or should be taken individually. And we should not advise timed intercourse. So we have to be comfortable with the uncomfortable things as fertility physicians. So the final aim is to make both man and the woman be happy and overcome their sexual dysfunctions with our brilliant censored focus therapy and other things what we have learned as pharmacotherapy even. Thank you.
Thank you so much, Madhubala ma'am. It was an excellent session, taking in depth about sexual dysfunction and infertility, starting from ICD classification, telling about it as a psychosocial challenge, and also infertility being a cause of sexual dysfunction and sexual dysfunction being a cause for infertility, both the ways, and also as you have dealt clearly that it is overlooked in infertility clinics, basically the sexual health, and also you were talking about intrauterine insemination by the couple in rural clinics, which was very new, and talking about timed intercourse performance pressure also is very important, which is important point to be taken in sexual dysfunction, and also the female dysfunction, female sexual dysfunction in the form of vaginismus, dyspareunia, everything covered in detail. Thank you so much, ma'am. So
Thank you, madam.
explaining to the couple is utmost importance has been very much stressed. Thank you, Madhubala ma'am, for the excellent talk, which is very less dealt with in our clinical scenarios. Thank you, ma'am.
Thank you.
Thank you, Madhubala ma'am. Really, it was a comprehensive, very informative lecture. You have covered everything in details.
Thank you, sir. Thanks for the opportunity.
Yeah, I have heard this topic many times, but yours was totally different. I'm also having this topic, but your content was very nice and very in depth. Thank you so much.
Thank you. Thanks for having this opportunity. I was able to read thoroughly about all these
Yes.
things.
Jarani ma'am, would
Ah,
like to have your comment.
I'm
Hello,
sorry.
Jairani ma'am.
Hello, hi. Hi, sorry. 1 minute.
Would you like to give some comment on this topic?
Yeah, I think Madhu has approached that in a very nice way. Very practical points, what we should see in the practicality, because people who practice more, like more patients, when they see they will come through these difficulties, and that is the very great difficulties. Whatever she said is practicality, which is the need of the audience needs that only. Because instead of talking all the subjects, it is always good to talk about the practical, that is the time intercourse, how it's have an impact, and the ejaculation, difficulty in collection, and also intimacy loss, psychosis, stress of the fertility itself, infertility itself, and how it impact their personal life. All these things makes a very great practical issue of this infertility and sexual relationship. So as it is, Madhu has made it in a very nice way, that very practically she has approached, and I really appreciate. Not to the regular context, it's talked in a different way, and that is really interesting, and that is the one which everybody likes, and that's it.
Thank you, ma'am.
Thank you, ma'am. Yes, thank you, chairpersons, for chairing the session. Thank you, Meena ma'am.
Thank you, sir, for the wonderful opportunity. Thank you,
Yes.
Prerna ma'am, for the wonderful
Yes.
opportunity.
Thank you so much. Yes, we will move on to the panel now. Mayur, can you share the slide? Jare ma'am, thank you so much for joining in spite of struggling with your throat.
Yeah, I'm not well.
Oh, yes, thank you for joining.
Taking IV antibiotics.
Yes. Yes.
When you ask, I cannot refuse. Even Prerna, when you ask, I can come from anywhere.
Yes. Today we are going to discuss panel on psychosexual issues in adolescents, which is very sensitive topic but very important topic. We have got fantastic expert, Dr. K.S. Jayarani Kamraj ma'am. Everyone knows ma'am. Ma'am is a wonderful person, wonderful speaker, wonderful Foxian. Yes, she is the chairperson, Foxy No to Violence Against Committee, and the past president of Oxy. I welcome all the panelists. Can I have the CVs, Mayur? Yes. Dr. Punguthai Selvaraj, ma'am. Ma'am is the president of Tirupur Society. Welcome, ma'am. Dr. J. Uma Brinda, ma'am, is the secretary of Thanjavur Obstetrics and Gynae Society. Dr. Pushpalata Kumari, ma'am, is the secretary of Vellore Obs and Gynae Society. Dr. Dhavasri, ma'am, secretary of Salem Obs and Gynae Society. Dr. Ashwin Rao, National Coordinator, Foxy Ethics and Medical Legal Committee, and from Salem Society. Dr. Gayatri, ma'am, who is the Secretary of Tirunelveli Society, and Dr. Swati Rathod, ma'am, past Secretary of Vellore Obs and Gynae Society. I welcome all the esteemed panelists for this panel. Yes, Mayur, let me share the screen. I think Dr. Prerna is busy in some surgery. She will join late. I will share the screen. I welcome all the panelists. Yes, it's a very important topic. Is the screen visible?
Yes, sir.
Yes, okay. We all know adolescence is the very crucial period in the life of a person because it is the transitional stage of physical and mental development, and that occurs between 10 to 19 years. So many factors influence this adolescent sexuality. The main factors are the gender identity, sexual orientation, the culture you live in, and how your body develops. These four factors affect so much. in the development of adolescents. Puberty is an important landmark of sexuality development that occurs in the adolescents. And this myriad of changes that occurs in adolescence put them under stress, and so many behavioral issues also, psychological issues also, that can affect their psychological development. That is why understanding these adolescent psychosexual issues is very important, clinically, legally, socially, as well as culturally, and also with the educational implications. There are three main domains as regards this. Cognitive development is there, emotional development is there, and the sexual development. We will go into the details slowly. Then psychological development in adolescence, how it occurs. There are some biological changes, some psychological and social changes. Biological changes occurs in puberty. Some effects are due to the hormonal changes and development of secondary sexual characteristics. Psychological and social changes which affect the sexuality are the cognitive changes which happens, and some emotional and social changes, and the behavioral changes. Then which are the common psychosocial issues in the adolescence? Just just to enumerate these are the sexual orientation and identity conflicts. Many adolescents are confused with their sexual orientation and their identity issues. And psychological factors like stress, guilt is there. Many times they face anxiety, depression, some sort of trauma may be there, and some sexual issues like premature ejaculation, erectile dysfunction, loss of sexual desire or pleasure may be there. And the most important is uh, they are facing about the myths and misconceptions about the sex. Many times they Google this information and may get the wrong information, and may develop the many misbeliefs. And the worst part is the pornography. Many adolescents are indulged into watching porns. There are other problems in the adolescence, like menstrual problems are there, childhood marriage is there, um, early and unprotected sex, sexually transmitted infections are there, teenage pregnancy and its complications. These are also rising day by day. At the same time, there are unsafe abortions. There are many cases of sexual abuse since childhood. Some addictive behaviors are there. And also, due to this increasing stress, um, many adolescents are facing the problems of depression and suicidal tendencies. So our focus should be on identity crisis, teenage pregnancy, and sexually transmitted infections more. We will have some case scenarios to discuss some practical issues. The first scenario is you have entered the room of your 16-year-old son and found him masturbating. What next? What will you do? What will be the first step?
First, we have to tell that it is not an abnormal thing. It's a normal adolescent sexuality phenomenon only, and we have to tell them. We have to tell him that it's not going to result in any infertility or sexual dysfunction in his later life, and it's not at all abnormal. So that assurance we have to reassure that it's not an abnormal phenomenon. It's a part of normal thing.
Yes.
Adolescence.
Yes.
Very, very interestingly, Madan, I would like to say at this juncture, WHO, they encourages masturbation because this is a way of a safe sex. So their adolescence age, instead of having a partner relationship, which increases the risk of STI, pregnancy, even WHO says that, even World Association for Sexual Health, we recommend or we say that it is one of the safe practice in adolescent sexuality to delay the first debut of their sexual intercourse. Masturbation is the better choice, and they even encourage that in the schools in the adolescent age group to have a safe. The sexuality can be safe sex can be well practiced, and that should be encouraged. They should not feel the guilt of it. They are not supposed to feel it's a wrong thing. It is a pleasurable thing which they can do for us, for themselves, but it should be only certain responsibility. It should be there. It should be confined to their personal level. That's how we should look that into it, into this masturbation.
Yes, ma'am, you have rightly said that this counseling part is very important in such cases because the people in adolescents are many times confused with this because of inadequate knowledge, and and we have to handle them very smoothly. Okay. Then next issue about the sexuality education. Should the sex education be part of school education and from what age? What is your opinion? Yes, anyone can take this question.
Yes,
What
it
do you
should be a part of sex education, should start as early as 8 years of age itself. Actually, sex education will not lead to early sexual activity. Actually, it delays sexual activity because the information which are given during sex education, like the anatomy of the sexual reproductive organs, like about the menstrual cycle, pregnancy, and about the consent and about contraceptive methods. So all these things to be discussed in during sex education, and this will actually delay their sexual activity. Adolescents can have sex, but should not be an early one. Suppose if they are not informed properly, then the peer pressure and social media will take over, and it will lead to unsafe sexual practices and early sexual activity. So sex education is at school is very, very important, and it should be taken for consideration.
Yes, ma'am, you have rightly told.
Madan,
Yes, ma'am.
UNESCO has given a statement that the CSE sexual comprehensive sexuality education can be started even at the age of 5 years, because this not they have to know about their body, they have to know about their genital, they have to know about their so it should be a age wise. They have given a very clean curriculum age wise, and it is very useful for the parents at that age 5 years, because they start even at 3 years from the by the parents, because they have to know about the body parts correctly, they have to know about their genitals very correctly, private parts, and they should be taught about the good touch and the bad touch, and they should say no to their unfeeling, a feeling of this discomfort. Everything has been clearly given even from the age of 3. So ideally, it should be started between 3 to 5 years by the parents. They should teach them to know about their bodies, because many times we don't give them. They give a wrong name of the private parts of the body, so they don't know. They will get confused. This goes into a lot of problem of gender dysphoria, which happens in a later age. So ideally speaking, at 3 years itself, they have to talk about their body. What is the body? Which is the name of the part of the body? And what is the role of it? Everything should be taught as and then up to within the. So that is why they given us a very age based and religion based and culture based study. So it is defined very beautifully by UNESCO. So it start even at the age of 3 years.
Yes, ma'am. I agree with you. As early as possible, it should be started, and at the same time, parents should be educated about this. And second thing is the right information at the right time should be given. That is also very important. Recently, in the December 25, Supreme Court of India has also stated that sexuality education should be started before ninth standard, not the after 10th or 12th. Recently, Supreme Court of India has stated in case of rape. So, it who is the right person to teach the subject?
Parents are the right person. Actually,
Yes,
parents are the right persons.
parents are the right person, but at the same time, we have to teach the teachers also because they are also handling these kids in schools. Also, they should know what is sexuality education. But the poor part is that in India currently, the sexuality education is officially banned. It is not allowed in any state. But as we as Foxy societies, um, we try to go in schools and give the sexuality education, give some adolescent health lectures. But this is going unofficially. It should come from the government. Then it will be very effective. If we ask the government for official permission, they are not giving the permission for this sexuality education. That this should be part of school curriculum. When interacting with students, what is your experience about the knowledge of sexuality among the adolescent girls and boys? Yes, anyone. What is your experience? What the students know? What they talk with us when we go in schools? What are their questions?
But generally,
Sure.
they don't ask
Sure.
anything about this sexual activity at all, actually, because it's considered as a taboo in our society. Nobody talks about the sex. Instead of asking us, they search information from the internet and from the group. So they share knowledge among their peer group, and they search knowledge from internet only. So they don't ask, they feel ashamed. They feel it is a taboo, it's a kind of fear they have, so they don't ask all these things with us. But that has to be removed from their mind. That we should feel, make them comfortable, and we should make them fear free to ask any question regarding this.
We found
Actually,
ma'am,
yes.
sorry to interrupt. We found a way of, getting the students talk. We put a box where there's no CCTV coverage. We let them
Yes.
put in the questions inside, and we do it after a week. We have a meeting where we open all the questions, and the previous day we open the questions, find out what the questions they have, and then we kind of answer those questions. And usually we send the teachers away, because with the teachers we cannot answer a lot of questions. So we actually send the teachers, or usually the students and us, and we identify the questions and answer them without pinpointing the person. There's no name in that question. So we were able to cover a lot of things. Usually it's a lot of guilt. They think talking about sex or feeling a sexual desire is a very wrong thing. As ma'am said, it's a taboo in our society. So we did that anonymous, questionnaires on answering.
Yes, ma'am.
Yeah.
I agree with your
So
point.
I
because
agree.
this
I
is the
agree with Gayatri and Pungale madam, because all our Indian studies are very limited regarding the adolescents' awareness about the sexuality. It is very low, and they get all the bits from everywhere, because even now the teachers, they don't talk, the parents, they don't talk. They get their information from the peers or from the pornography, because pornography they have in their hands. They have everything in their mobile. So there is definitely inadequate knowledge about sexuality among the Indian adolescents. There is no clear knowledge for them. They always, all the more, as Madam said, it's a myth. They still believe it is a taboo, and they still get a lot of myth about this adolescent sexuality. So they always keep that, parents always have control, or parents always ponder over it, and that is why they don't have much of knowledge. It is very limited knowledge they have. So definitely the misconceptions about the sexual health is still very much prevalent. So that is why the Indian scenario, it is very less knowledge. Nearly they said about 80% of the, even the Indian adult 18-year-old, 19-year-old, they lack knowledge about sexuality. That's what they've given, a clear lack of knowledge. So information, only they get some bits of information, and the scientific understanding is very poor. So that is why when you give a scientific understanding with a CSE, these children will get a proper sexuality, awareness when they grow up to the age of 15 or 16. So right from year 5 or 6, we should start, and around the 10 years, they should be given a proper guidance. Because nowadays, if you look into the Indian scenario, the girls get puberty very early. They get puberty at the age of 8, 9 is nowadays very common at 10. Before their emotional maturity, before their any maturity, they get the pubertal maturity, and all the hormones started doing all the hormonal changes. So we should be well preparing our children to face this reality of early puberty, early experience of the hormonal changes, your crush feeling, alertness, because there is so much that is very much happening in the schools. We did one small study with the students from 8, 9, 10, and we really were astonished to see how vivid they have their knowledge in a different way. So in that way, definitely they need much more education, much more awareness, and definitely our studies are very limited. I think, Madan, you have to take it up in your committee work as a chairperson when you take over. You must do this because my passion is always CSE, and
Yes.
that's the reason I contested in that. So you must be taking this CSE into the schools, which should be really beneficial for all our adolescents to know the sexuality in the proper context, proper way, and that will give them a better facing the future in a better way.
Yes, ma'am. Actually, we should work on the sexuality education implementation. And as Gayatri ma'am has rightly said, whenever we take a program in the schools, 1 to 2 days prior, a box should be kept for the questions. We get lot of questions. There are so many questions in their mind, and we can answer these because they are not going to ask openly in the open program. They are not going to ask, but without disclosing the names, we can have a lot many questions. So now we are moving.
Scenario 2, Dr. Madan.
Yes, welcome, Prerna. Yes, you can take, please.
Welcome all our esteemed panelists and our expert, Dr. Jairani Madam, and heartiest greetings from both of us. And we are really looking forward to this esteemed panel for a warm participation. With the scenario 2, as we take forward this panel, a 19-year-old
Done.
unmarried girl comes for consultation, and she's in a steady relationship with her boyfriend and wants to take things to the next level. So we are wanting a contraceptive advice for these adolescent girls. Any of the panelists, Dr. Punguthai, Dr. Yeah, you can take her.
Yeah, Pushpalata ma'am.
Yes, we can give her contraceptive advice. Before that, we have to advise her about safe sexual practices and also about HPV vaccination, other things and all that has to be informed prior. And we can advise her about the contraception. We can advise barrier methods and also she can follow OC pills also.
I would be very
And,
thankful for the patient coming in before she taking the first step, because usually we see her pregnant. That is when they start thinking. So I am very happy she actually came before that. And not only avoiding pregnancy is the key, we are also have to avoid all these sexually transmitted disorders. So we need to educate them about all those things and also tell them there is no fashion or forced sex. Since somebody is doing it doesn't mean we have to do it. I think it is more of a competition. It's just come to a competition in this in that age group, that she's getting laid, I'll get laid, something like that. And actually, we need to sit and spend a lot of time with these girls talking about it, and she has to do what is comfortable for her. She should not be pushed into doing something which she doesn't want. So
Very
my
true.
first advice.
Something which is comfortable. And Dr. Jayarani, ma'am, can you give your expert inputs on this?
Yeah. What Gayatri said is I agree, because there's a right. She's coming to you means itself that shows that she's very matured enough, and that also she wants to have a very planned way. That is also well appreciable. So first and foremost, we have to give them a space proper, because this type of a counseling is very important. We have to put them the scientific nature of the sexual act. What are all the things that can happen with the sexual act, right from the STA, right from the abuse, right to the pregnancy. Everything should be explained properly. And then, of course, about the promiscuity, we must tell her. And we have talked about vaccination. And also, we should tell them a good, clear view. I mean, since she has come to you, you have to give her everything about contraception. And the best way that you have to give them a double protection. And also, very important, the STA prevention. And also about she has to see who is a partner, what is their relationship with other partners. Everything has to be very much taught. And ultimately, it is always very important that we have to give them the ABC. ABC is what we know that's what, now you're given the topic, abstinence, barrier, contraception, combined pill, and of course, D is delay in sexual act. A, B, C, D, E. Up to this, you have to give. A is abstinence, B is the based on the values, core values you have to see, and the C is the condom, and D is delay in the first debut, and E is the emergency contraception. And these are the things that we should educate the teenager. So we must definitely give them all the proper guidance. We cannot give them a choice. We have to give them the decision. See, if you are going to do a sex, it should be done for two things. One is protection of your STA and so condom plus medication, because sometimes condom can fail. So you must be very careful. Condom is for prevention of STA and your contraceptive pill is to prevent the pregnancy. All these things should be very clear to them. That should be there proper.
And a
Thank you,
completely
ma'am.
non-judgmental place. Completely non-judgmental.
Of course, there's no judgment. She's coming to you.
Yeah.
So she's not, she's now very empowered. That's why she has come to you. So it is our duty and responsibility to respect her, not to be judgmental. You have to respect her and appreciate her that she has come to you, because that's right. As Gayatri said, she didn't come with an unplanned pregnancy. She has come for a counseling, pre-sexual counseling. So that's a very important aspect. You should appreciate her and give her the proper guidance.
Thank you, ma'am. Quite an insightful perspective on contraception of adolescents. And Dr. Ashwin, you want to add something to this?
Can you hear me? Huh?
Yes, you're audible.
Actually, nothing much to this part, but again, this part about parents. I mean, is the slide question is what I want me to take or something else? Is
Yeah,
the
you
question
can
on the
take
slide
this.
is what you want?
Yeah,
Okay.
you can take this.
So basically, if her parents are friends, and then if you think that she's in bad company, then I would obviously want them to know that something is happening, but talk to her in confidence and see what she's got to say about it. Because we don't really see, basically at that particular age they're not able to assess as to what would be the right companionship that you can have and all those things, and whether it'll affect her school or college life is all the things we take into consideration. And obviously here one more thing that we consider is if they're a friend and the child considers you as an important personality in her life, it's better that you don't really bring it out and tell her parents, because and in front of her, because then you may lose her trust. That's one thing I find here.
No parents involved. If she has come to you, you will talk to her as an adult. And I do not think I have the authority to talk to the parents here. Even if they're my closest friend, then I'm very actually honored that the kid could come to me and talk to me. I don't
think that
unless
she's
she's
come to you.
it's not a major, then the whole scenario is different. But for a major person, I don't think, because she will not come back to you at all.
I think this is not a major, I think, on this patient. Is she a major?
This 19-year-old.
Yeah,
19.
this
Okay,
19.
okay. In that case, then confidential is maintained. Okay. I thought she's a minor. Okay. Fine.
Yeah, we have to maintain the privacy and confidentiality.
Yes.
Absolutely. Even since just because they have come to you, though you know their parents personally, you have to be very cautious. We can have the medical ethics of not revealing this to the parents at any cost, right?
Yeah,
That's very important. But certain, of course, nowadays the children are very smart. Nowadays the adolescents, they are very smart and they know all the human rights. So they really ask for everything nowadays, because I'm seeing a lot of change when they know teen pregnancy, unmarried pregnancy, people they come, they're not bothered about who accompanies them. They say we want a miscarriage, when we want to have an abortion, medical abortion, give the tablets, my doctor. That's what they ask us. So,
Jarani ma'am.
Yeah.
Please keep your laptop little closer.
You can't hear me?
No. If laptop is closer, your voice is clear, very clear.
Okay. It's a desktop. I didn't even bring my laptop.
No, now very clear. We'll move on to the next scenario. A 20-year-old female student comes in your clinic. She recently had unprotected intercourse with a new partner. She has had 2 other partners in the past. She is asymptomatic, but she is worried about contracting infection, and she wants to undergo any investigations you advise. Then how will you approach this case to manage?
She had unprotected sex with multiple partners, so there is more chance of a sexually transmitted infection. She should be thoroughly screened for all STIs, including bacterial vaginosis and including HPV testing also for her.
And also, madam, we should ask the partners also to be tested. That's very important.
Definitely, all the partners should
might
also
have
be
had
tested.
an infection, and she could have given the infection to her partners.
Yeah.
So all the partners and the contact of the partners has to be checked. If it is an unprotected intercourse suspecting infection, we must do the screening for the partners too. That's very important. That's just a social responsibility. You have to tell us a social responsibility that they have to screen. Otherwise, there will be we will be spreading the infection, HIV, and everything.
Yes, ma'am. Yeah, at the same time, the proper history and proper counseling is very much necessary in such cases. And as she is adult, and she has come for us about all the investigations, then we can advise her.
Blizzard model of proper history taking to be adopted for this type of a history taking. You have to make the Blizzard model, because many times they may know that they have an unprotected intercourse, but they may have multiple partners, but still we have to give the Blizzard model as a very strict one, so that you can identify everything related to her sexuality.
Yeah. At the same time, we should educate her about the all the STIs. Yeah. Yeah. We all know there are 5 P's of sexual history. The partners, practices. Partners mean number and change of partners and their genders. Practices means the type of intercourse you have. The protection, whether they have the knowledge and about the use of frequency of the contraception, and past history of any STI or the treatment taken for the same, and whether she knows about the ways of to prevent the pregnancy and about the contraception, and that will take out the complete sexual history. Okay, then we can ask the what are the symptoms regarding the men and women also, and as per the history, we can advise these investigations. We will not go into the details. Just next scenario: a 17-year-old female student comes to you and explains that she has recently been attracted to her best friend, who is a female. She feels afraid to accept this, as all other friends are attracted to the people of the opposite gender. She thinks that she will be ostracized by the peers and the society. Then how will you guide her? How will you counsel and guide her?
Can tell her it's not at all abnormal to get attracted to the same gender, and
yes, she can have feeling for the female. It is not an abnormal, but we have to counsel her very calmly, and also we have to explain at the same time. There are so many cases like her which comes under LGBTQ community, and we should support this community. This is not an abnormality, because the different people may have the different sexual preferences.
So even lesbian activity comes under POXO, because any sex under 17, she's 17, below 18. So it comes under POXO. She may think that doing sex with the opposite sex will have a POXO impact, but we
even
should
the
tell
same
her
sex, it comes under POXO
it comes
Act.
under POXO.
Okay.
Any gender, when they have sex with any gender below 18 comes under POXO. It's very important.
Yes, but in this case, just she has come to us for that she's having feeling with the partner of same sex. Yes, you are right, ma'am. But what is important is to coming out. That means we have to this. It is their complete decision to choose or to do so or not. We have to explain the importance of coming out, and the supportive
She's just
environment is
17.
very important. Yes.
She's just 17 years. She doesn't know how to make decisions and all. So we can guide them to come out of this exit.
But
Because
it's a good thing that she's expressing her feelings. That is a good thing.
So
yes, Dr. Ashwin.
We should tell her this adolescent age is an age of curiosity, because this is the age that they feel everything to be explored, everything to be checked. So that is the nature of their age. So that age will always make certain things very curious. So that is why many a time they have a very curious and they have an emotional attachment, which is very common. With someone showing a love and affection, they don't bother about the age or the type of the person. Immediately they are very attracted to them and they are very much attached to them. The emotional attachment is very common at this adolescence. And also
Yes.
they will have always an identity. They will have their own identity. Oh, they are loving me so much. Why can't I love them? They are giving importance. So identity is also very much their belief. when the person whom they talk with says, "Oh, you are very good. You are so pleasant to move with," so automatically they feel, "Oh, I'm being given respect. So why can't I reciprocate?" So that is how they always go. And also they will always be curious to do some experimentation also. That also is
Yes.
very common. So this behaviors is very common with adolescents. So we should always think that this girl being very curious with her same sex, it always she feels that it is something in attraction. So we should tell them, you're not mature enough, as Kumare madam said, you're not in the right age to decide certain things. Your emotional maturity is faster than your basic your brain maturity. So you have to give time. It is not, we are not judgmental, but at the same time, we should have like a discussion. We should talk with them in a discussion. Why they are giving 18 years for the driving license? They know that is the time that your brain matures. That's why the whole world gives a driving license at 18. So you wait till 18, you will be a different person to the same perspective. What you are perceiving this act will be very different in 18 because your brain matures, your brain neurons. So like that, we have to guide them. We cannot be judgmental. We cannot say, no, you should not do that, this and that. We cannot say, if they do that, they will not open up with you. So ideally speaking, that we have to encourage them. I mean, make them talk about it, get them into the discussion, get the scientific. If you cannot do, take her to a doctor or to a counselor or to a therapist who can guide this girl in a better way so that that will kindle her thought about this attitude towards the same sex.
Yes, ma'am. Yeah. Yes, this is the section 377. There is change by the Supreme Court of India in 2018. The Supreme Court of India ruled that the application of section 377 to consensual homosexual sex between the adults, that was unconstitutional, irrational, indefensible, and manifestly arbitrary. But the section 377 remains in force relating to the sex with minors, non-consensual sexual acts, and the bestiality. This we should know about this change in the 377. Yes, regarding this, we have the next scenario. The school authorities report that some students of standard 9 have caught watching porn. They want to address the students about the same. They also want your opinion whether concerned students should be punished. If you are called for this act as an expert, as a doctor, then what is your take? How will you counsel the students? Yes, anyone?
The curiosity towards this kind of pornographic viewing this pornography and all is common in this age group. So we have to counsel them. Actually, they should not be punished. We have to counsel them accordingly, according to the age, because they're too young, and we have to tell them about. We have to advise them what is good and what's bad.
Yes, we can counsel them properly. We have to explain them the bad effects of the porn also and how it will affect their sexuality. And other behavioral implications are also there in future. It may affect their personal development, some performance in the school, and some sexuality issues that should be addressed well in a polite and cool manner. We cannot punish them at present because they are handling the Google continuously. They can have this material at any time. That is why we have to handle these adolescents very coolly and calmly.
We should also tell them, as Madam said, it's a curiosity that makes them see the Googling, see the pornography. We should tell them that pornography is an unrealistic one. It has been taken
Yes.
with the purpose of people to watch, and it is not the reality. You have to tell them it is an unrealistic, act which is being shown in the pornography, because they believe that that's the realistic act, and they go for all the psychological problem of erectile dysfunction in future. So automatically they feel that their penis should be so much long, so much wide, and my penis is smaller. So all these thinking starts by watching the pornography, and you have to tell them it is really an unrealistic things to see the pornography. So they must be educated that, and they also should show the pornography. They don't give any respect. They don't give a proper consent, and they do all these things that very unrealistically behaves. All these things has to be entrusted in the child mind, that any sexual act should be done with respect, with consent, with proper understanding, and also with a proper realistic physical changes. And the mind also, the this will give them a good way of a realistic expectations what they can do in future, and it will definitely make them behave in a better way, to look that sexual act in a better way. That's how many studies have told about watching a pornography by a 15-year-old or 16-year-old. That's it.
Yes, ma'am. So, what are the social and behavioral implications? There is a great impact on the relationship also. It will affect the self-esteem, and it is definitely going to affect the school performance of the student. They may involve in the risky sexual behaviors, and the consequences of this we also know. That is, the sexually transmitted infections are there. Some unintended pregnancy due to unprotected sexual intercourse is there, and the challenges mainly we are in concern are the coercion, sexting, sexual abuse cases are there, some misconceptions about the sex in their mind, and drug addiction is again a rising problem in the society in the adolescents. So we have to be careful about these implications. And as a doctor, the question is how to address these psychosexual issues in the adolescents. How we can address? Yes, anyone can take this. How to address these psychosexual problems?
We have to
Thank
tell
you.
them about the.
Yes, Dr. Ashwin? Or-
So basically, what I would feel is to address this. One thing is about electronic media is the commonest cause why this comes into play, and a lot of times when they are actually browsing into different websites and stuff, what happens? You get cookies which they accept because thinking that is a game. So electronic media is a commonest cause, and
Yes.
more physical activity and getting them involved with other kids and keeping them active is something very important. And as far as schools are concerned, what we would say is actually having a proper counselor follow, because there'll be certain kids who are actually sitting in a corner not getting involved, and it's more likely those kids might get into bad habits is what I would consider. And those are a few things which I think about it.
Okay. Yes, Pungutai ma'am.
And we have to inform about the chance of sexually transmitted infections, and also about the unsafe abortions if they get pregnancy.
Basically, we have to educate them. We have to give
Educate them, yeah.
information about the sexually transmitted infections,
Yes,
how
yes.
it occurs, what are the symptoms, what is meant by contraception, which are the types, when to use, how to use, and importance of safe sexual practices, so that unintended pregnancies can be avoided. And we have to promote the positive attitudes, and also that is the importance of education, open and respectful communication, because it is the key. Communication, open communication is the key, and to remove the myths and misconceptions from their mind, that is our job during the counseling. And at the same time, we have to give the psychological support if they are having any problem, psychosexual issue. We have to deal with very cautiously, gently, and coolly. And of course, there is a role of parents, educators, and healthcare providers. We are the healthcare providers, but at the same time, we have to teach the parents also, because they are in contact with the parents and educators, teachers also. They should also know the basics of these things. Okay. Then some recommendations for the parents are there. Not to give a smartphone to the child until the age 14, not to have computers or other electronic devices in their children's room, but we should have the access of them, these things. And also daily check the which sites they have visited, which the browse history should be known. And uh, children are very smart, they delete the browse history. That also should be watched. Then talk with the parents of your children's friends and update them on the realities of internet pornography. And so many things are there. What is the role of family and society? This is the last part. Role of family and society. Yes, role of uh, every person is there, like parents, brothers and sisters, role of relatives, friends, family friends, teachers, school, so sport coaches, healthcare providers, religious leaders, also traditional leaders, role of musicians, film stars, sports figures, politicians, journalists, bureaucrats. All this should contribute to this issue, because everyone is a responsible part of the society. Yes, we have come to the end of the discussion. Jairani ma'am,
Yeah.
would you like to add something?
Yeah, you're given a very comprehensive way. That's good. We all should take. I mean, we cannot be judgmental. Whenever we come across our children or their friends or their adolescents who have a problem, we should understand that this is the age of curiosity. They are very much experimental. So it's a way of attraction. Everything happens there. We should educate them properly in the scientific ways. We should tell them about the hormones. We have to tell about the pubertal changes. We have to educate them about the relationship. We have to talk about the consent. And everything has to be talked to them. We cannot just leave anything, no, this is wrong, you cannot do this. We are there to guide them. We cannot do the judgmental or punish them or wrong thing, comment, negative, say about negativity. All these things should be avoided. If you are doing that, the adolescents will not open to you. That is very important. Because the adolescent, the teachers, the teaching, we don't have a comprehensive sexuality education. The teachers don't teach, the parents don't teach. Their teacher is the internet, peers, and only their friends who don't know anything, who are even lesser than them. But if they are open to them, they will guide them wrongly. So you should tell them that they don't know. That is a one important thing that you have to put into their mind. Even a 1 or 2 years senior to them, they think that they are like, they know everything. So they can guide them. So that thinking should be taught different. And about the pornography, you must talk to the 15 or 16-year-old about the pornography, because every child after 16 knows about pornography. You must tell them it is an unrealistic expectations. You will see what in that. There is no scientific basis in that. So they cannot be taken that pornography as a guide for the sexual act. Even with adults, everybody think that the pornography is the guide for sex. So that is a very wrong way, you have to say. The internet pornography has to be given a proper way that we should talk to them, and we have to give them the scientific basis of their bodily changes, hormonal changes, what the brain changes, the maturity level, when it happens, when they are prepared for the sex act. All these things should be given, and the decision should be left to them, but we should be very strong in guiding them in that way. So they need a strong points, not just an advices. They never take up the advices. So these are all something that we have to look into it, and definitely we have to talk about the abuse also, because abuse is nowadays very common. We have to get the leading questions put to them about the sexual abuse, which are very commonly we are seeing. So we must talk to the abusers also to the children. So adolescents are a very vulnerable age. You have to be very careful, because their thinking will be entirely different from your way of thinking. You may think the same perspective in a different way. They will think, for them, even one friend who is not talking for a day means like a life ending. Oh, he didn't talk with me, what I've done. That will make them more guilt, more anxious, more think. They never think the realistic way. So they may even go up to suicide. in that way. So we should be very careful in handling the adolescent's mind. That is very, very important. So all these things has to be taken care when you're dealing with adolescent sexuality.
You have covered
Madan,
or
you made me think a
summarized.
lot. Madan, you made me think a lot after a long time. After coming to violence. Nowadays, now you made me think a little about my CSE.
No,
Thank
you
you
have
so much.
summarized the
Thank you.
entire
Thank you.
topic.
And I wish you and Prerna very good luck. Hope you come without any opponent.
Yes, thank you.
That's I wish
Thank you so
and
much.
I wish and pray.
Yes, thank you so much. Thank you all the panelists, Punguthai ma'am, Ashwin, Gayatri ma'am, everyone contributed very well. Thank you for joining. On behalf of AMOGS, I would like to extend my sincere thanks to all the Tamil Nadu societies for participating in this webinar. And thank you, AMOGS office bearers, all the chief guests, guest of honors, and all the faculties who have joined today. And we
I
are very
request
happy to
everyone
connect.
of you to put vote for Madan and Prerna in the upcoming election.
Yes, thank you so much, ma'am.
They
Yes.
deserve. They deserve.
Yeah, I need support from entire Tamil Nadu. Thank you so much.
Okay.
Sure.
Bye.
Thank you.
Yeah.
Thank you for the opportunity. Thank you, ma'am.
Thank you, Jayanand madam. Your
Thank you.
contribution is
Thank you.
excellent.
Thank you. Thank you so much.
That's
Yes.
excellent.
Yes. Thank you, Corona Remedies, for the support. Thank you, Mayur. Yeah.
Thank you very much, sir. Thank you all.
Yeah. Yes. Thank you. Yeah. Good night.
Thank you. Good night.
Good night. Good night.